The broadcast is now starting. All attendees are in listen-only mode.
Good morning and welcome to this new webinar of the Maternal Health Supplies Caucus of the RHSC. I would like to welcome all of you and ask you to be a little patient. Let's wait for 2 more minutes. We already have 13 attendees, but we're expecting many more. We have 65 registrants. So let's give 2 more minutes to people to register and to be online. 2 minutes. People are still coming in, so that's the reason why I'm waiting a little bit longer. I can see people entering the platform, so let's hold on for 1 more minute. Very popular webinar, Hans. 18 people already.
Okay, that's nice.
That's very good. Yes, and more coming in. So I'm giving them 1 more minute. Okay, I think it's time to start. Let's see. Okay, time to start. So welcome to this new webinar of the Maternal Health Supplies Caucus. My name is Milka Dinev and I backstop the Maternal Health Supplies Caucus. I have been with the coalition now for almost 5 years, and it's always a pleasure to organize these webinars and to showcase the work of our members. In this webinar, we will have a presentation prepared by the Concept Foundation. Hans Wemmer and Melody Larson from Concept Foundation will be presenting progress, challenges, and opportunities to registration and availability of quality assured maternal health medicines in Ethiopia. All the participants have been muted, so we don't hear the background noise of your offices. So your microphones are all turned off, and we will leave your questions to the end of the presentation. But please, while you're listening to the presentation, if you have any question, there is a frame, one of the little squares in your screen, where you can write your question and we will get to it as soon as Hans and Melanie finish presenting. This webinar is being recorded and we will have the video and audio available in our website. I will also be sending you an email thanking you for your participation today, and I will send a link to the recording. You will be able to see the link to the recording in a YouTube channel that is dedicated to the RHSC. Do not hesitate to contact me through the chat window if you have any difficulty or want clarification. I repeat, all the microphones have been muted, and make sure you have a good pair of headphones and do close any other programs in your computer so that you have enough bandwidth. This is especially a recommendation for people calling from other continents. Make sure that all programs in your computer have been closed. With no more to do, I will pass the baton to Hans. So Hans, welcome, and the floor is yours.
Well, thank you very much, Milka. Good morning, good afternoon, good evening, wherever you are. Very glad that you're listening into this webinar where Melanie Larson, our program officer, and myself will be speaking. This webinar will present the results of a program funded by the Innovation Fund of the MacArthur Foundation through the Reproductive Health Supplies Coalition and partly funded also by the Packard Foundation. This is an overview of what we plan to share with you today. We will briefly introduce the project and explain why there is a need for more quality maternal health medicines in Ethiopia. We will outline the design of our assessment, the tools that were used, and we will highlight the thematic areas considered during each step. And we'll present our results and present our recommendations. And then we'll have hopefully 15 minutes or more for questions, answers, and discussions. A few words about the Concept Foundation. Concept is working on saving women's lives and women's futures by helping to increase availability and access to high quality, low cost, generic sexual and reproductive health medicines to women in low and middle income countries. And globally, we are assisting partners with manufacturing, with quality certification, with registration, and if needed, with market introduction of these pharmaceutical products. And this way, we hope that women and men worldwide have an equitable access to sexual and reproductive health products of assured quality at the lowest possible price. Concept works in 3 areas: family planning, maternal health, and that's what we were talking about today, and safe abortion. And with that, I'll hand over to Melanie. We'll make sure that you don't hear the same voice the whole webinar. Melanie.
Right. Thanks, Hans. So I'll share just a brief background why there is a need for increased access to quality assured maternal health medicines. So why maternal health? Every day, approximately 830 women die from preventable causes related to pregnancy and childbirth. This is every day. 99%, the vast majority of all these maternal deaths occur in low and middle income countries. So of this 830, more than 220 women around the world die from severe bleeding during and after childbirth or postpartum hemorrhage. And PPH is the biggest cause of maternal death, but for a large part, it is avoidable with good and affordable medicines. Globally, our goal is that we want all women to have a safe and uneventful pregnancy and delivery, resulting in healthy children. If we look at the situation in Ethiopia, it is the 4th largest contributor to global maternal deaths. It has a maternal mortality ratio of 353 per 100,000 live births. So this is a dramatic improvement of the MMR. It has declined from 1,400 in 2000, but still it accounts for an estimated 11,000 maternal deaths occurring each year in the country. In Ethiopia, PPH and preeclampsia, eclampsia are also leading causes of maternal mortality. But luckily, oxytocin and misoprostol, they are effective treatments and they're recommended for the management of PPH. For prevention and treatment of preeclampsia and eclampsia, magnesium sulfate is the recommended medicine. And improving maternal health, it does remain a top priority of the Ethiopian Ministry of Health. This is outlined in the Health Sector Transformation Plan, and specifically the MOH aims to reduce MMR to 199 by the end of 2020. In recent years, the UN Commission on Life-Saving Commodities for Women and Children made a recommendation for increased availability of affordable, quality-assured life-saving commodities, and this includes oxytocin, misoprostol, and magnesium sulfate. However, there were a number of concerns that were raised with regard to the quality of the drugs. So studies have revealed that numerous products are available, they are registered on the market, but they are of substandard quality. And this is often the result of improper transportation, storage conditions, but as well poor manufacturing practices that simply do not comply with international standards. So while there has been a push in recent years, we've seen an increase in the number of quality assured products that are available. Access does remain limited in countries where maternal mortality is highest. To address this lack of supply and access to quality assured oxytocin, misoprostol, and magnesium sulfate in high need countries such as Ethiopia, the report Increasing Access to Essential Maternal Health Supplies by Results for Development, and it was commissioned by the RHSC. They recommended supporting manufacturers of WHO pre-qualified medicines to register and introduce their products in low and middle income countries. So Concept Foundation, in response to this recommendation, we undertook a landscape assessment in Ethiopia to support manufacturers towards product registration. And Hans will share more details about the design and methodology that was used.
So how did we do it? What we aimed to do with the landscape assessment in Ethiopia was to make sure that suppliers and national public sector actors have the same information and leverage the findings to support manufacturers towards registration in the country, and thereby to accelerate access to these WHO pre-qualified medicines for maternal health. And this assessment examined available evidence about structures related to registration, supply, and procurement, and it identified specific barriers to accessing the three essential maternal health medicines, oxytocin, misoprostol, and magnesium sulfate. The assessment in Ethiopia was conducted in collaboration with the Merck consultancy in Ethiopia. The mixed methods approach that we show here consists of quantitative and qualitative research. The document review. The exploration started from a comprehensive document review of available data that made analysis of the country context possible. Then we developed and carried out tailored, semi-structured interviews to three sectors procuring medicines, the three sectors being the public sector, the private sector, and the social sectors. And the interviews, the surveys, gathered information on procurement, quality issues, policies, and the supply chain. Then qualitative data collection methods included key informant interviews to gain a deeper insight into the current situation of the regulatory mechanisms, the supply chain, and quality related to these three drugs. And finally, two focus group discussions were held as part of the workshop organized by Concept Foundation in Addis Ababa in Ethiopia. These workshops were held in Addis, these focus groups, as part of a workshop to increase access to these maternal health medicine And the workshop included delegates from the Ministry of Health, FMHK, the National Drug Authority and Regulatory Agency, manufacturers of WHO pre-qualified medicines, other NGOs, and service providers. The aim of the workshop was to create a venue for engagement and for improved communication by the supply and the demand sides by bringing together key stakeholders. We wanted to reduce the information gap that existed around regulatory mechanisms and market dynamics for oxytocin, misoprostol, and magnesium sulfate that should lead to facilitation of registration, procurement, and ultimately access to quality-assured maternal health medicines in the country. The preliminary findings from the early assessments were shared with the group, which provided an opportunity for further enrichment and consolidation of the findings. And the focus groups also contributed to the development of recommended actions to take forward.
So I'll share now some of the key findings from our assessment. So looking first at regulatory, the Food, Medicines and Healthcare Administration and Control Authority of Ethiopia, or commonly known as FMHK. So under the Proclamation 661/2009, which has an objective to safeguard and protect public health, FMHK has the mandate to ensure that all medicines, whether they're produced locally or if they're imported, but those that circulate in the market and are used in the country are safe, they're effective, and consistently meet acceptable quality standards. So FMHK is granted to regulate the manufacture, distribution, marketing, prescription, labeling, dispensing of pharmaceuticals, and post-market surveillance. And the National Drug Policy of Ethiopia, from which the proclamation is based, it requires that quality assurance measures occur at various stages. So during manufacturing, shipment, storage, along with testing at different time points before it reaches the end user. The overall responsibility and accountability for all aspects of medicine regulation is distributed vertically between FMHK centrally and regional state regulatory bodies. So FMHK, they have several regulatory functions. Among them includes registration. So FMHK, again, they have the legal basis for marketing authorization of pharmaceutical products. They provide guidance for applicants and standard operating procedures for assessors. And like other medicines, oxytocin, misoprostol, and magnesium sulfate registration is carried out by the Registration and Licensing Directorate of FMHK. So this agency is therefore responsible for reviewing application dossiers. They review all post-registration amendments as well. Foreign and local manufacturer GMP inspection teams of the Directorate evaluate dossiers, and then they also conduct these inspections. Through our assessment, it was verified that foreign manufacturers must appoint an authorized representative in Ethiopia in order to register their products. So this means that all imports must be channeled through an Ethiopian national that's registered as an official import or distribution agent. And some manufacturers that we spoke with of WHO pre-qualified medicines reported that this is actually a key barrier to entry. Also related to registration, maternal and child health medicines, which include these three medicines that were the focus of our assessment, they are among those that are eligible for fast-track registration. FMHK also participates in the WHO collaborative registration procedure. This is a fast-track process for WHO pre-qualified medicines. FMHK, they're also responsible for the National Essential Medicines List, which it currently includes over 400 medicines, and among them includes oxytocin, misoprostol, and magnesium sulfate. When we examined the national EML with international guidelines, it mostly aligned. However, for magnesium sulfate, the presentation differs. This is important as medicines are registered and the government issues tenders and procures medicines and supplies that are consistent with the national EML. And so this can impact WHO pre-qualified medicines that are consistent with the WHO EOI and their model list of essential medicines. And in order to provide quality services as recommended, FMHACA also issues different standard treatment guidelines. This includes indications for the first, second, third line medicines recommended for prevention and treatment of PPH, as well as active management of the third stage of labor. So FMHACA reported that all medicines included in the national EML should be easily available at affordable prices, but unfortunately approximately 75% of medicines are not registered presently. So if we look at this table of registered medicines for oxytocin, misoprostol, and magnesium sulfate, you can see that oxytocin and misoprostol, both packaged alone, and we've indicated co-packaged with mifepristone as a combi pack, they have gained market authorization from FMHACA, but magnesium sulfate is among the 75% that are not currently registered. If we examine product registration and quality, around half the products are quality assured. So again, when we talk about quality assured, we're referring to products that have been approved by a stringent regulatory authority or pre-qualified by the WHO or recommended by the WHO expert review panel. But it's just important to highlight as well that for the purposes of this assessment, we were unable to verify whether any quality assured products in Ethiopia are actually identical to those approved by the SRA. So this can be in terms of having the same formulation, composition, specifications, packaging, etc. So quantification in Ethiopia, it's done collaboratively among the Pharmaceuticals Fund and Supply Agency and agency within the Ministry of Health and the Federal Ministry of Health through the Pharmaceutical Medical Equipment Directorate and a technical working group. So based on the information that was shared by the Ministry of Health and by PFSA, we can see here that there were large variations in the forecasted demand for oxytocin and for magnesium sulfate. For misoprostol, however, we did not receive figures from PFSA, but clearly there was evidence of problems of coordination and quantification. What we learned through further discussion with PFSA is that the gap in estimates is in part attributed to a resource gap. So they explain that part of the process of estimation is based off of the disease burden as well as consumption, but a critical component is available resources. So in the future, it was determined that PFSA will be leading forecasting estimates, and they indicated that they will be accounting for this component of the available resources in their calculations. When we compare figures now from shared by the Ministry of Health of what was procured against what was forecasted by the agencies PFSA and the Ministry of Health, again, we see here large variations. So, for example, for oxytocin, the procured supply was double the estimated forecast by the Ministry of Health, whereas for magnesium sulfate, the procured supply was significantly lower than quantified estimates by PFSA. And I'll just highlight the two main sources of supply for these medicines include the Revolving Drug Fund, the RDF. This is the standard process for maternal drug supply at PFSA. And the second main source of supply is from its partners. And UNFPA, they're the main contributor towards the maternal drug supply in the country. They procure the medicines through their own bidding processes. They handle requirements for imports and customs, but then all medicines are distributed by PFSA. And it's just to highlight as well that UNFPA's quality assurance policy prioritizes WHO pre-qualified medicines and may be responsible for some of the quality assured medicines found during our assessment.
Let me then now talk about the product availability. And on this slide, you see oxytocin, misoprostol, and magnesium sulfate with brands available, whether or not they are quality assured and whether or not they are registered with the price range that was found. Well, availability in terms of quality, the choice of brands and whether a product was registered varied by commodity. Again, it's important to notice that it was not a representative sample. The information gathered does not paint a complete picture, but rather tries to provide some insights into the market dynamics. Interesting, only half of the products reported were registered at the time of the assessment. However, there's unfortunately no clear link between product availability and those that are quality assured and registered, as only a limited number of products met both these criteria. Looking at oxytocin, we found 4 brands available in the market. Only 1 product is registered. Products reported were quality assured, and a pre-qualified oxytocin was not available or not registered. Across the sector, the price range for oxytocin ranged from as low as 15 cents to a little over $1 per ampule of 10 IUs. For oxytocin, as well as for the other medicines, they were typically lower priced in the public sector than in the private and social sectors. We know that essential products in the public sector are subject to price controls, which helps explain some of the price variation. For misoprostol, 5 brands were reported, including misoprostol packaged alone and misoprostol co-packaged with mifepristone. Only 1 misoprostol packaged alone and 1 combi pack were both registered and of assured quality. For misoprostol alone, the price ranged from 15 to 74 cents per tablet. For magnesium sulfate, we found 2 products available. Neither are registered, but UNFPA was procuring magnesium sulfate, actually a quality assured magnesium sulfate, and this may help to explain the availability of this quality assured product. The price ranged from 20 cents to $1.11 across the sector. Price versus quality. In regards to price as a consideration during procurement, most of the respondents that we talked to reported that quality was prioritized over price, although we saw differences between the public and the private sectors. Around 40% in the private sector told us that price was prioritized, while others suggested that limited supply and competition were the driving factors for selection. Whatever is available, we buy. As such, there was no opportunity to prioritize based on price or quality, but they rather choose the only option available. Quality issues related to the 3 products were reported with low frequency during the surveys. However, probing deeper during interviews with key informants, some respondents expressed a degree of uncertainty about quality, but regarded market authorization by FMHACA as an indicator for good quality products. But as we have seen earlier, unfortunately, approval by FMHACA did not always guarantee that products are quality assured. One key informant expressed this uncertainty around product quality when discussing failed inductions of labor. She said, "It is partly because the uterus doesn't respond and I don't know. It may also be the drug that is not working. It is difficult to know for sure what is the problem, and if I am uncertain, I double the dose." I'll share another example from the social sector that depicts the gap in supply of quality assured products and how others are addressing the supply issue of quality assured misoprostol. While Metabon is a quality assured mifepristone misoprostol combi pack indicated for the termination of pregnancy, One key informant indicated that providers are using sometimes the misoprostol from Medabon for postpartum hemorrhage management in cases when the available and registered misoprostol that is packaged alone fails, citing issues of potency or effectiveness. Let's look at the manufacturers. As part of the efforts undertaken for this project, Concept Foundation engaged with all manufacturers of WHO pre-qualified oxytocin, misoprostol and magnesium sulfate to encourage their participation in the assessment and to offer technical support towards registration in Ethiopia. The pathway isn't always linear, but registration is a key milestone that is routinely critical to increasing the number of products moving along this continuum from engagement and commitment towards registration, introduction, and increased access to affordable, quality-assured medicines. Manufacturers along this spectrum, Zizou, which produces quality-assured, pre-qualified misoprostol and mifepristone, participated in the project and also in the workshop. They continue to express an interest and they are taking required steps towards registration and of a combi pack, and if all remains on track, they plan to submit a file very soon. AS Calchex produces quality-assured, pre-qualified magnesium sulfate. They attended the past workshop organized by Concept in which they were able to engage with local agents to support with registration. And while they did not participate in this assessment, they confirmed that they plan to submit a registration file this year. INRESA also produces WHO pre-qualified magnesium sulfate and participated in the assessment and the workshop through an agent. As mentioned earlier, we did find limited reports of INRESA's product being available in public health facilities. However, it is not registered with FMHK. The company reports they have plans to do so. GSA Grindex, who actively participated in the assessment and the workshop and received some technical assistance from Concept, reports they also plan to submit a file for registration of their WHO pre-qualified oxytocin. And Cipla, which manufactures WHO pre-qualified misoprostol, did not require technical assistance, but through engagement with Concept expressed an interest in the Ethiopian market, and they recently confirmed that they submitted a file for their product misoprost to FMHK. Well, this is a summary of the barriers found during our project. In registration, some products found in the market still lack registration, and the process often takes longer than 6 months, which is the official goal. Quantification, the estimates were not aligned between the Ministry of Health and the Pharmaceutical Fund Supply Agency. Forecasting is a major challenge also for manufacturers. In supply, we saw shortage, frequent stockouts of maternal health medicines, and an inadequate number of brands. And a lack of adequate technical support and follow-up were also reported. Storage and distribution. The mechanisms to ensure a cold chain during distribution and storage were mentioned as a big barrier. And also delivery of small quantities of products was reported to increase transportation costs. Knowledge and perceptions of perceived benefits of procuring low-priced, lower-quality medicines versus those that are quality assured at a slightly higher cost. Resource constraints are a major barrier to access, affecting quality assurance mechanisms and registration. And in capacity, this relates to staff turnover, shortage of pharmacy personnel, and need for skilled and qualified personnel. In tenders, pre-qualified products are often disadvantaged compared with low-quality product if price dominates. The National Essential Medicines list is not fully aligned with the WHO EML or international guidelines, and poor LIMS creates great challenges to clearly monitor and track the supply and the stock out. And finally, coordination. This is related with other barriers, such as quantification, supply, distribution, and resource commitments.
So with consideration to these key challenges that were faced by multiple stakeholders at different levels and functions, we propose a set of key recommendations to address these obstacles and support continued efforts towards increased access to quality, affordable maternal health supplies. So looking at regulatory efficiency, we have put forward two key recommendations. The first is increased commitments to support regional regulatory harmonization initiatives. So Ethiopia, they're currently a member of the Intergovernmental Authority of Development, or IGAD. It's a regional intergovernmental body. However, IGAD lacks adequate funding for medicines regulatory harmonization. By increasing commitments and resource availability that is dedicated to harmonized registration and collaboration between FMHACA and IGAD member states, for example, on initiatives that could include harmonization of technical requirements based on best practices or WHO prequalification standards, or conducting joint evaluations of dossiers and GMP inspections. This could have several positive outcomes. It could simplify and improve efficiencies of the current complex and quite fragmented regulatory landscape in the region, eliminate the need to submit multiple dossiers. This can stimulate competition, incentivize manufacturers to pursue product registration in more African markets. And it can also reduce costs and time that are required by regulatory authorities and manufacturers, which may help to lower prices and fees, also facilitate faster approvals, and accelerate more timely access to medicines in Ethiopia and in the region. Our second recommendation is to increase resources to strengthen regulatory capacity. So as we mentioned, around half of the products found during our assessment were actually not registered. And further, we had several accounts of anecdotal reports of possible quality assurance issues with available products. So taking these considerations, taking these factors into consideration, as well as the reported high staff turnover and loss of skilled personnel, and FMHACA has actually suggested that they may be required to outsource some of their regulatory functions. There is a greater need for adequate and predictable financial and human resources to ensure that FMHACA is able to serve as a fully functioning regulatory body in order to ensure the safety and efficacy of medicines in the country. For procurement and supply, we also put forward two key recommendations. The first is strengthen forecasting, supply planning, and procurement processes for maternal health commodities. So it was acknowledged by the agencies that quantification should be improved, that addresses barriers around quality and timely data, and more accurately identifies needs, gaps, and also accounts for resource availability. This will also require increasing knowledge around some of these gaps between the quantification and commodity procurement, and then really enhancing the coordination among stakeholders. So these efforts will ultimately, hopefully, work towards preventing supply shortages and wastage to better ensure a more adequate and continuous supply of maternal health commodities. Our second recommendation is to support manufacturers of quality assured medicines to identify trustworthy, authorized local agents to facilitate registration and procurement processes. So what we learned is that identifying a reliable agent serves as a big challenge that can either dissuade manufacturers from registering their medicines in a country. It may also significantly delay the registration process. So by undertaking initiatives to further support other manufacturers of quality assured medicines, it can help to remove this barrier. It can increase awareness among manufacturers around procurement and tendering processes, which also may be a barrier, and support them with registration and introduction, further accelerating access to these life-saving commodities.
And finally, as a way forward, some recommendations looking at and how we can take the lessons learned from the experience in Ethiopia and leverage this to increase access to quality assured maternal health medicines. 3 recommendations. First, improve awareness around quality assured medicines to generate demand by providers and among women for these products. There's still a lot of work to be done in this area at all levels, from policy ministry level to the facility and provider level, and among sectors and others involved, whether they are financing or procuring the commodities, exactly what we are doing with oxytocin right now. This can mean increased advocacy at local and regional meetings, publication in scientific journals, and following the oxytocin example, articles in the lay press. Secondly, prioritize quality assured maternal health medicines, quality over price. The assessment found that medicines procured and available in the public sector include commodities of assured quality, but also those that may be registered that have not undergone a rigorous review by SRA or WHO Prequal or the expert review panel. And thirdly, support the opportunities for information sharing among regulatory and health ministry officials, procurement agents, service providers, and manufacturers of WHO pre-qualified medicines. The workshop demonstrated to be a very useful tool to bring together key players, provide discussion around findings, but the key players each had a unique and critical role. One of the barriers mentioned frequently was the lack of knowledge of the local market and contact with local agents to support product registration. This was one of the accomplishments of this workshop that we had. Manufacturers that attended reported that through the workshop, they were able to engage with stakeholders and agents to initiate a dialogue. And those conversations have been fruitful and have led to agreements for working collaboratively and bringing quality assured products to the market. And we want to emphasize the real value of these opportunities for future replication and the role they can have in supporting registration and access to quality assured medicines. I want to thank you all for listening, and I want to thank the MacArthur Foundation for the Innovation Fund grant through the Reproductive Health Supplies Coalition, and I want to thank the Packard Foundation for further support to Concept. Thank you very much.
So thank you very much, Hans and Melanie, for this presentation. It's fantastic work, and I'm very glad that Innovation Fund funding was available for you guys to do this job. Let's open now the floor for questions. We start. I think we can start. Let me open questions here. Just a second. Okay, so first question here comes from, I'll read the question and then you can answer. From Beatrice Gatumia. If medicines are available and not registered, does that mean that patients are using them? It's not clear to me.
Yeah, so we did find another number of products. We had that table up that was previously that indicated or showed that around half the products that we found through assessment, it wasn't a representative sample, but we did find about half of them are registered, so about half are not. So yes, they are using medicines that are not registered. So FMHACA, they've indicated that there are certain medicines that can that are eligible to be waivered. So this may, for example, with the UNFPA, magnesium sulfate, this may be how it potentially entered the market. But again, you know, it could be potentially WHO pre-qualified medicines, but as well, we found that there are medicines that were not qualified, that are not registered.
Thank you, Melanie. We have a second question from Kabir Ahmed. In terms of barriers, what about the incentives for manufacturers? because most of these medicines, even though they're life savings, they're not procured globally in huge quantities. And as such, the manufacturers don't have any commitment to produce these medicines, and there is no motivation.
Well, thank you for the question. Great to hear that you're online, Kabir. I must say that is a very valid point, but it's a little bit of a catch-22. If there are no pre-qualified or quality-assured medicines procured by countries or with the help from donors, then there is no motivation for companies to go for the process of pre-qualification and quality assurance, and even SRA approval. So, and if you look, and indeed, relatively small quantities are now procured. But if I may call it the market for these medicines, also in Ethiopia, is really much bigger than what is available now as quality assured products. So if regulatory agencies and if organizations like you and like Gates Foundation or etc., if they are really focusing on only giving money to procure quality assured medicines, and quality assured, I mean SRA approved or WHO pre-qualified or ERP approved, then that will give manufacturers a motivation to really go for these for this qualification. So we must break that vicious circle and say, if you only are allowed to procure quality assured medicines, then there will be a motivation. And as we have shown, for oxytocin and for misoprostol and for magnesium sulfate, there are enough many pre-qualified and quality assured products available, at least for Ethiopia. I hope that answers the question, Gabriel.
Thank you so much, Hans. The next question from Kate Kikule. Thank you for the presentation. Were you able to determine whether the products that were not registered had either been authorized by FMHACA or had gained entry into the market without FMHACA knowledge?
Yeah, that's a very good question. It somewhat, I don't mean to repeat, but it somewhat goes back to the example that we provided in regards to the magnesium sulfate that was available in the country. We found it at limited public health facilities there. Some of the medicines that were available, for example, there was an oxytocin product, and during our assessment, it was not registered. However, it was this kind of gap between the renewals. So since completion of our assessment, the primary oxytocin that is being procured by PFSA the market authorization has been renewed. So that was in late December. So there are these instances where there may be gaps simply due to renewal. And then there's these other instances where some products enter the market based off of these waivers, whereas in Ethiopia, I mean, it's not unique to Ethiopia, but you see other products that are on the market that are not registered, and they've entered as, counterfeit or falsified products as well. So yeah, so it's not one kind of blanket answer. There's various channels how it could be entering the market.
So your response gives weight nicely to this next question by Helen Pitak. Can you describe the Ethiopia registration process in more detail? For example, how long does a registration remain active, and how expensive is the registration process?
Yeah.
The registration, hello Helen, the registration remains active for 5 years, and then it has to be renewed. The prices.
Well, in Ethiopia, sorry, Hans, it's 4 years, and then it's up for renewal. The registration in terms of costs, it is $4,000 to $5,000. So it's based off of
dollars.
Dollars. It's considerations of if the manufacturer is local, if it's a foreign manufacturer. In terms of the process, they would have to submit a dossier, it would have to go under, there would have to be a premise, GMP inspection conducted, there would have to be fees. We found it was fairly consistent with other regulatory authority review processes.
But a more detailed description of the review will be in the report, in the written report?
Yeah.
Yeah, so Helen, it will be our pleasure to send that written report to you so that you can see in more detail the registration procedure. I think it goes too far to describe it in great detail now, but we can send it to you.
The next question from Dick Jungst. How is it possible that magnesium sulfate is not registered? However, it is found in public health facilities. Is it a discrepancy between PFSA and how the registration by FMHACA? How is their collaboration?
Yeah. Thanks, Dick, for your question. Yeah, that's a very good question. And again, it goes back to it potentially, I mean, I can't verify, but they've indicated that UNFPA is procuring some of the magnesium sulfate. And what we did find for magnesium sulfate was a WHO pre-qualified product, which, you know, obviously aligns with their quality assurance policy at UNFPA. So there are waivers, so it could be that it's waivered. But again, another challenge that we mentioned before, even though we found this WHO qualified medicine available in the market, is that the EML, the national EML, does not align with international guidelines. So through discussions with FMHACA, they've expressed that it could, you know, if there's substantial evidence and rationale to demonstrate that it should be registered, it could be registered and procured. But again, that does remain a challenge, is that the EMLs are not aligned.
Yeah, and indeed, it could very well be that UNFPA got an order and received a waiver from FMHACA, right, so that it's not registered and it is available. The good news there, although it's not registered, the good news there is at least it was an affordable, quality assured, pre-qualified product that was available. Yeah.
We have a question now from Debbie Armbruster. Did you find 5-IU oxytocin during your assessment? Was there a significant amount of 5-IU available?
So again, this was not a representative sample. We did purposive sampling. We did find that limited amount, but I couldn't give you a certain percentage in terms of which proportion of public health facilities have been procuring and making this available. But yes, we did find that during the assessment.
And then we have a question by Andrea Baer. Thank you for sharing this very interesting work. Could you elaborate on whether and how the barriers varied by the sector? Were the registered and pre-qualified products more likely to be available in one sector versus another?
You mean
public and private, I imagine. Yeah.
Yeah, probably public versus private versus social.
No, I mean, we didn't find any real direct links. So, for example, oxytocin, what was, as I mentioned, the main oxytocin that was available in the public health facilities was not registered, but this was due to the lapse in marketing authorization. But it is quality assured. We found this, whereas, for example, in the social sector for oxytocin, we had limited reports, but there was the registered product was actually found in the social sector and not in the public sector. If we look at misoprostol, we more commonly found misoprostol packaged alone in the public sector and private sectors, but less in the social sectors. And we found registered products across all sectors. For quality assured products, we found for misoprostol, it was limited to one product in the social sector. So really again, this just kind of emphasizes that there isn't really a strong, clear link between product availability of what we found and those that are registered and those that are quality assured.
I don't see any more questions. Thank you, Melanie, for that last. Oh, I'm sorry. I do. There's one more question here. Just came in. Veronique Dupont. Veronique is asking, what did you learn from this work about how to best engage local agents, distributors? I understand that working with local commercial distributors on the registration of maternal health products can present some real challenges, as local distributors tend to prioritize non-maternal health products that offer the highest return on investment. Could you share your thoughts about what you learned about how best to engage them?
Well, first of all, it can be a challenge, but at least in Ethiopia, and that's what we're talking about, one has to have a local agent and a local distributor to get registration. You cannot come in from wherever country and say, I have this product and I want it to. So you need a local agent. Secondly, yes, it is true that a local agent, like every business person, will prioritize a product with a higher profit over a product with a lower profit. On the other hand, the agent that we have been in contact with and agents that we have been in contact with in other countries, they are at the moment definitely not having a surplus of product in their portfolio. They are really looking for products in their portfolio. And how to go about. What we noticed very clearly is the fact that they were literally sitting at the same table across each other really helped to get to know each other, not to communicate by email or by phone, maybe to make an appointment, but to sit together in the same room. That made a real difference. And I mean, the first success is already Cipla, who is registering a product now, which they were not in the past. Oh, I hope that answers the question. You want to add something, Melanie?
I think that answers it. Did you have any other questions about that?
I think her question is more of what are the best practices. You said some of those best practices in dealing with local agents are to just get them to talk to each other. So that's one. Anything else that you would like to mention about? Yeah.
Well, check with the regulatory agency in a country who are respected distributors and agents. If you ask them, or you ask them, if Concept asks them, we'll get answers, and they give us one or two or more respected, trustworthy local agents, and then contact these people directly and talk to them and explain what you want and why you want it, etc. That's also how the magnesium sulfate product became available, through a local agent.
Let's do this last question. This is the last question. I think we have reached the hour, from Martin Boss. Thank you for the interesting presentation, Hans and Melanie. This is Martin Boss from Medical Expert Group. Also interested in report on registration procedures, status for key products. Please share. Greetings from Johan and Martin. So they're not asking a question, they're asking for the report. So we should probably, as soon as the report is finished, we should probably upload it in our website, right?
Absolutely.
Absolutely, yes.
Yeah, we actually had shared it previously with one of your colleagues, but we can ensure that it gets to you as well.
But what we can do is probably share the report with the whole Maternal Health Supplies Caucus, and we can put it in the library of our listserv. That will work fine, I think.
Yeah, that would be great.
Yeah, that would be great. That would be
All
great.
right. So your final words, Hans and Melanie. It's been a very, very good presentation. Thank you so much. And you have the floor to close the webinar.
Well, we together want to thank the sponsors and the listeners and everybody who participated in Ethiopia and in Merck and in the Merck consultancy in Ethiopia. And I heard that's even one of our great helps. The guy who was really helping us in Ethiopia, Dick Jungst, was apparently on the call. I want to thank everybody that they made a commitment to place quality over price, because that's the only way we're going to save women. Thank you very much, all of you.
Thank you.